Once upon a time, life used to be a Puritan process, and medicine used to be the science and art of healing. The medical profession was meant only for the few blessed ones, people with a passion to heal, working to earn something priceless, good karma.
Hi, good morning.
Hello. Good morning.
Good morning, Dhaka, and it's our pleasure to be participating in the National Heart Foundation conference today. So, good morning to all our friends in Dhaka. I'm Dr. Hiremath and Dr. Chandrasekhar Makhale. Both of us have been to the cath lab in Dhaka. I come a number of times. So today we have two left main ISR cases for you. We propose to finish the first one in first 15 minutes, which is already done. And then we will show you live the second left main ISR. So can we have the first images? The first case is one homozygous familial hypercholesteremia. And the first stent is deployed at the left main ostium going across the mouth of the left circumflex. So this time she was only 11 years and we have done this case in 2003. So she was amongst one of the youngest in the world to have received left main stent for atherosclerotic heart disease at that time. She also had a stent in the proximal LAD, a little bit away from the first stent. In 2004, we check angioed her and everything was looking good. So she has cholesterols like 800 plus. She's on 80 milligram of atorvastatin with ezetimibe. And we have tried various combinations. Her LDL still remains around 180, 170. And we are very, very hopeful that PCSK9, when it is available to us, is going to be a great drug for her. So she has remained pretty asymptomatic till about a month back when she had what looks like an ACS. Her TROP-T is positive at this stage, and this is her angiogram. Dr. Makhale?
Yeah, so this angiogram shows the left coronary ostial instant restenosis. There was a significant wedging while we were doing the diagnostic angiogram. The rest of the bifurcation looks good, but although there is stent crossing across and a distal LAD stent appears to be patent. You can also note the severe calcification of aorta because she being the familial hypercholesterolemia, and also there is a significant family history of the same disorder. We intentionally used here.
Actually, her sister had a bypass surgery with a calcific supravalvular aortic stenosis when she was about 17 years in 2005. And she is pretty good at this stage of time.
On the superior aspect, you can see that we have made side holes in a guide catheter. There is a contrast which is jutting out, so that has helped us doing this plasty.
So during ostial left main handling, many times we use this, the side hole. If you do not have a catheter available, you can actually make the holes on table. And the other deviation that you can see here is instead of usual EBU catheter, we have used a JL guide catheter. So we have taken a JL 7 French just to be ready in case if we need to do a bifurcation stenting. Generally, we are going to limit ourselves to the ostium, so we do not expect that we'll be taking 2 stents at any stage. The first old stent has actually gone across the mouth of circumflex. This was Pronova stent, India's first DES, immediately after Cypher was born on the scene. So you need to prepare the bed very, very well. So we have a wire across, then we get a 2O balloon.
Next.
Then we have a 2.5 NC balloon. You can see the balloon is kept intentionally into the aorta so that it doesn't slip off. And then we come in with a cutting balloon. This was a 3O cutting balloon. So whenever there is ISR, I think cutting balloon should be a strong consideration. So we bring in Zions expedition stent here. You can see the stent comes in pretty easily, and we are now trying to position it at the ostium. All of you saw that the ostium is critically diseased, partly involved in the ISR. So it is very important to keep a part of the metal proximal to the ISR, floating a little bit in the aorta, free aorta. So RAO-cranial or AP-cranial is one of the view, and this I think we check it again, LAO-cranial. Luckily for us, we have an old stent which is positioned perfectly, so we are going to position it slightly proximal to the old stent. Stent boost, of course, would be of great help at this stage. Okay?
Yeah, and also the advantage of the calcium also, which tells about the where exactly is the ostium.
So this is a 4012. We inflate it, then we post-dilate it after pulling it back, the balloon. This is a 40 NC balloon, slips in very easily. We do some high-pressure inflations. And we, of course, are using stent boost, and this is towards the final pictures of the left side. We did an IVUS which showed a very well expanded stent. So at this stage, we will take out the wire, and these are some final pictures taken with another catheter. So this has no side holes, which is a regular diagnostic catheter. This girl also has RCA ostial disease. Many of you might think that the disease is not very critical. So at this stage, we did an IVUS for her. And IVUS, run this again. So this is a pretty big circulation. The circumflex also is a very large circulation. So based on IVUS, we decided we will go ahead with the stenting to the RC ostium. Again, any ostial lesion preparation is very, very crucial. So we prepare it with a non-compliant balloon. Then we bring in a cutting balloon. In this particular case, considering she's very, very young and has to go a long way, we decided to use BRS, the absorb stent which is available to us. As you know, the absorb needs a very good bed preparation. So here we have prepared it with a 3O NC, 3O cutting balloon, and we are now ready to bring in an absorb stent. So we are taking 3.5/18 absorb. We have the GT1 also available to us. The absorb comes on a different shaft these days, which is going to increase its pushability. And we'll be able to reach many other lesions which we used to feel that absorb may not track. Having said that, Makhale and I have a couple of cases where we have taken absorb through Lima loops to the vein grafts and so on. So we are quite comfortable taking absorb to any distality. So here is an absorb with the mouth. This is not a GT1, which is a newer version. And we position it at the ostium. We feel that absorb could be placed a little bit more in the aorta because everything is going to go away at some stage. So you can take more liberty with absorb at the ostium compared with the conventional stent. And this is dilatation, then dilatation done with a non-compliant balloon. And we are coming to the some of the final pictures. So this is a final picture of the RCA.
Now you imagine the vessel, which initially what we saw was very small at the ostium, has really grown up with a 3.5 millimeter absorb here. And the entire total circulation is dependent on that on the right coronary artery.
So this girl has moved from age 11 to age 25 now, when she has required a second procedure. The other remaining coronary arteries look pretty good.
Actually, you saw her in the promo. She was there in the promo. This girl we saw there.
So I think we did all the talking. Yes. So maybe we have comments from you all.
Dr. Hiremath, I am Dr. Badir Zaman from National Heart Foundation Hospital. We have got panelists with me, Professor Afzalur Rahman, Professor Abdul Wazir from Dhaka Medical College, and Dr. Fatima Begum from United Hospital. I have a few queries. First of all, the osteal lacement looks highly calcified, and you have pre-dilated with cutting balloon. Uterus heavily calcified, because if for example, cutting balloon failed to expand this lesion, what would be the next step for you? For example, you have tried with a cutting balloon and still it was not expanded, and it's already stented left main. What would be the next option?
Actually, here part of the calcium is in the aorta too, not necessarily at the ostium. You already have a stent there, and through a stent, rotablator generally is not a nice option. I think we probably have just 2 cases where we have done a rota inside a stent because we are not getting enough expansion. But if cutting balloon is not crossing, we come back to a body wire and take it, try and take it.
The problem with the rotablation with the previously deployed stent, at times whatever the debris what you get is actually the metallic debris. Although it is a small in micron size, but it can lead to the trouble, particularly no reflow.
Cutting balloon, what's the next?
So it is not advisable to do the rotablation in the previously deployed stent.
So again, regarding the right coronary artery, the ostium of the osteoproximal looks very tight and calcified. And if you dilate it with 3O balloon, still after deploying the BVS, it was unexpanded, and you post-dilated with maybe 3.5 with very high pressure. So was it a better choice, or we should put a metallic stent here in such a calcified vessel, because you may need to post-dilate with very high pressure, and in that case, BVS, I don't know whether BVS is tolerant.
I think many people have this anxiety putting BVS in the ostium, but let me emphasize and re-emphasize that BVS can be stretched to any limits. You have to adhere to the balloon size. If you are taking 1:1, we have taken BVS to pressures like 26 and 28. Not an issue. You're allowed to go half size bigger and certainly quarter size bigger to get a good expansion. So I think by doing this, you generally should be able to get a very good expansion.
Dr. Hiremath, this is Dr. Afzalur Rahman.
Hi, Dr. Afzalur Rahman.
Thank you for demonstrating nice case. You are very experienced operator. But my thought is very basic. Did you discuss the patient about the CABG of this patient? Because it is a in-stent left main stenosis calcified. And did you discuss with the heart team discussion between the patient, surgeon, and the cardiologist? Did you have done that?
Actually, honestly, we don't have a very well-developed heart team in our hospital. I have my own thoughts that this girl, 2003, she had a left main stenosis, LAD critical stenosis.
That time she was 13
and that time also surgery could have been an option because drug stents were introduced just 2-3 months before. So somebody would have argued that she could have gone for a bypass surgery. We did not. because she was only 11 years and today she's only 25 years. I think age is a very, very driving force, and whatever restenosis you would get from these kind of procedures today is still very acceptable in longer term. If she does not restenose, I think she's done. She's going to go for another 10 years.
We are postponing the age of requirement.
Of the RCA.
Yes.
And regarding the ostium of the RCA, do you think that it is really tight, or you should do FFR for that RC ostium, or angiographically you see that it is really tight?
No, actually this was a discussion that even we had, and we did an IVUS here, and IVUS showed a critical narrowing.
Next.
So this view.
So your opinion is that for ostium severity measurement, IVUS is better than FFR?
I'm not saying that.
Particularly if the fibrocalcific
IVUS is better than FFR?
Particularly if there is a fibrocalcific lesion and we can measure the diameters there. Show me the next IVUS there.
I don't think IVUS or mid-shaft lesion reduces the value of FFR. FFR would still be very useful even to pick up ostial physiology. I think we just did not do it because we had IVUS opened up and ready for the left side. So we thought we'll continue with IVUS evaluation on the right. But I agree with you that you could have done a FFR.
Valid documentation. And regarding the IVUS of the left main, you have done the IVUS after. Why not you have done the FFR before starting of the procedure? Because in this case, anyway, you will do the IVUS, initial stenosis. So it is not good to have a look. So how far the calcium?
No.
It is a concentric or eccentrically on. Because I have seen that you did not done the IVUS before starting. You have done the IVUS after the implantable stent. That's good, but as the initial stenosis, lot of calcium. So what is the suggestion for you?
You look at this run what is on the screen right now. I think with this so much severe ostial stenosis, transiting the IVUS at the beginning will be little trouble.
Actually, we did IVUS in the beginning also. This was more to achieve the diameter because when she was a kid, at 11 years, we had put 3.5 diameter stent, and we had to know what stent diameter we should choose this time. So we did do an IVUS on the left side. So we did an IVUS on the left, pre, post, and then we did IVUS on the right, pre, certainly. Post we did, but absorb IVUS does not give too much information. You need an OCT to really see the stents deployed into the vessel wall. Okay.
Another query about what anti-cholesterol therapy she is getting and what is the cholesterol level now?
So LDL is about 170 to 180 at this stage with 80 milligram of atorvastatin and ezetimibe combination for many years. She's just about 39 kilos, so giving a bigger dose of any kind also is a big anxiety. So if you're done on the first case, we'd like to show you the second case. Are there any questions on the first case? Second case.
No. Thank you.
One question is that, Dr. Hiremath, it's a very nice case. And
Second case.
think I would go for your decision because she is only 25. What sort of cutting balloon did you use?
It's a conventional cutting balloon by Boston. It was 3.5 cutting balloon.
Yeah.
So we now come to the second case, which is again an ISR. This lady has ostial stent, which was 4x8, 2011. In 2012.
Question to the panelists. Dr. Hiremath.
Yes.
This girl, what about the marital status of this girl and whether she's going to have any children or getting pregnant in future? What will be the status of?
Oh, at the moment she just has a boyfriend, so I don't think we are thinking of. She's also thinking of any pregnancy. So we come to the second case. As I said, 2011, We have a 4x8 DES at the mouth of the left main. 2012, 1 year later, she had a tight stenosis at the mouth of circumflex. As you can see on the screen, the circumflex is a very dominant circulation. And I remember in 2011 when she was having an ostial left main procedure, the moment the guide catheter was engaged, she crashed and we had to go on balloon pump and finish the procedure. So 1 year later, she developed circumflex mouth stenosis, and this was stented with a short stent beginning at the ostium of the circumflex and going into a dominant circumflex. This was done as a part of live when one of the famous European operator was with us, and what we felt would be a bifurcation stenting. He finished like a kid's play in a few minutes. So this worked very well, and this lady remained asymptomatic for 6 years. And what we are seeing is current pictures. The LAD remains very healthy and long. The circ is dominant, and the spider view shows ISR at the mouth of circumflex and a tight stenosis at the mouth of the ramus. You can see the circumflex is a very dominant circulation in this particular view. See, this also shows that the first stent, which is placed in 2011, is functioning very well. So it's a very well expanded, very well positioned stent and functioning very well.
Let's take the opinion of the...
So come back, show the spider view.
Let's take their opinion. What do you say?
So, okay, freeze this. So can we have a kind of opinion from you all as to how one would really like to do the case? I mean, for us, stenting from left main to circumflex is a surety. The ramus is a sizable circulation, and it's already critically diseased, and all ostial lesions, I feel, should be stented and not going to be balloon dilated. There are many people who would use a cutting balloon on the side branch, that's the ramus, then put a drug balloon to finish it and avoid a second stent. But I think the way we use two stents and we have long-term follow-ups, we strongly feel that this should be done with two stents. Any thoughts from your side?
First of all, this patient should be offered the chance of the ABG if he agrees. I think because all the stent is there and the left main, the left dominant circulation, and there's a big ramus, or whatever call it, a high OM over there. If not, then we can go for the PCI, and in that case, in my opinion, we should put a stent from left main to LCS, circumflex, and we can do it.
What would be the sequence of stenting? Which one first and which one second?
I think first we should go for the circumflex first, because it's a big artery. In any case, we don't want to lose this by any means. So we should put a patient, then we can go for the ramus or whatever you call it.
Yes.
See, with the patent LED, I think there is no point in sending for the surgery. What do you feel?
Yes, that is also my concern.
Okay. Yeah.
That the LED is a normal-looking vessel.
Correct.
So why will put the patient for surgery? If the LED was lesion, then we can send for surgery.
Yeah.
Otherwise, we should go for straightway for PCI of this case.
Yeah.
And is there no discussion? No need
Thank
of
you for that.
discussion, hard discussion.
Yeah.
And yes, I agree with you.
We are all
So,
in the
my
angioplaster's
decision is
den, and we don't think of surgery so much,
yes,
isn't it?
Please. And you are the master operator, so definitely I agree with you and other colleague who told me that I will go for a stent. I will put two wires, one in L6, one in the ramus, and maybe you can put one wire in the LED if needed. And then I go for pre-dilatation of the L6 and also ostium, or I will go for pre-dilatation of the L6. Then I'll put a stent from the distality of the left main to the L6. Then I will go for plot in the second stage of the OM if it is needed. Sometimes the ostial narrowing like that, if you make a dilatation, you may have a good result. If there is no dissection, FFR is fine, then we can leave the patient with a single stent strategy. Otherwise, we can convert it. If there is a dissection, we have a long dissection in the obtuse marginal, or there is a FFR positive, then we'll go for the stenting of the second stent of the OM by port technique, tap technique.
Okay, so now with the paucity of the time, I think we'll show you what we did.
Here, one of our concern is the see the angle between left main and circumflex. It's a very, very acute vein, and the circumflex is a dominant circulation. So the first thought that comes to our mind is make the left main branch safe by stenting it, and then worry about the side branch. However, we are into the protocol study with Dr. Park, and we have excellent follow-up of left main. In fact, there are 3 years where we had 0 MACE in the left main 2-stent strategy. So we were pretty positive that we want to stent the ramus, and my another colleague, Dr. Gaurav, is here. He was a big push in saying that yes, we must stent both. So these are the steps which we followed. We have run through hypercoat wire, then balloon with TO, then a conventional wire in ramus, a balloon with TO, dilated both ramus and circumflex with a 2.5 NC balloon, and this is the kind of picture. So at this stage, which stent first, the side branch or the main branch? That was the discussion. And we thought we'll take the side branch stent first. The initial idea was to do a double kiss, double crush technique, because you always remember that in this case there is already a metal layer, there is already an old stent, so you are going to go through 2 layers of metal, and that's why we thought compared to a conventional crush, mini crush, a double kiss would be better before we take the main branch stent. So we are still working. Show the previous one. This is a cutting balloon, not crossing, and then we came in with a
2.5 NC.
What was that?
Scoring
that was a scoring balloon, and this one also didn't cross. Our experience is wherever cutting balloon doesn't cross, the scoring balloon crosses many times. It's a better profile, but in this case both fail. So we are dilating with a 3.0 NC very aggressively, and then we finish bed preparation. These are some sizing pictures, and then this is
next.
Show that tracking is pretty good. This is a stent. This is a Zion's expedition, which tracks very easily to the mouth of the circumflex. We get a balloon in the left main circumflex. We use stent boost, deploy the ramus stent, bring back the balloon, do a kiss. The idea at this stage was to do double crush, but patient became a little bit unstable as we were trying to rewire the circumflex. So we decided we'll come quickly to the circumflex. And this is balloon preparation. We are trying to crush the projected portion of the ramus stent, the back end. And I want you to see the Alpine. See, the Alpine has this CPS system, central positioning system. It's act like a bumper. You know, the car hits on a curve, it hits the side and still get pushed in the middle. Similarly, the Alpine has that kind of balloon length beyond the stent, which does not expand. So it allows you to sort of center the stent, and this is the beauty of Alpine. Of course, the added features like the shaft pushability, going through complex calcific lesion are all there. And with the Excel data, I'm sure we are going to look a lot more from this stent in coming years. So you can see the stent tracks very easily, and I had shown you this was a very, very acute angle between circumflex and left main. Yet the stent has no difficulty in getting to its location. So we deploy the stent. So then we did a pot with 4O balloon in the proximal portion. Then we went down 3O and 3.5, and this is where we had 2 stains. So this is a sort of a mini crush technique. And now we are ready for a final kiss. If we had done a double kiss, double crush, especially because there is 2 layers of metal in this circumflex, we would have felt getting into the side branch would have been easier. So we come with a cross 100, and actually we have not done double crush, but I think crossing...
No, that we did not do because of instability. Otherwise, we had a plan to do the double crush.
So this is actually what we use many times, fluoro zoom, which is on our Philips FD20 system. And you can see the cross 100 wire crosses very easily into the ramus.
Here
okay, so we are live at this stage. As I understand, we have about 6 more minutes, and I will re-engage. Can we put some contrast down?
Yeah.
1.5 balloon, please. Contrast. So we re-engage the guide catheter on this one. So any thoughts the way you would have done it? I think the way you decide to position the stents is going to be very important, whether side branch first or main branch first. I would have felt that circumflex is very dominant, and positioning main branch is crucially important. But just because we have lots of experience, we thought we can even have safety with going for the side branch first.
Dr. Hiremath.
Yes.
I am Dr. Abdul Wadir Chaudhary from Dhaka Medical College. I think the stent that was previously placed in the circumflex, and you have put a balloon in there and dilated the ISR, that gives us some sort of a scaffold is there. It's not going to collapse suddenly because they have opened up already from the inside and there is a metal scaffold. I think that your decision of doing the side branch flap first and then doing the main circumflex, I think that's the proper judgment.
Oh, thank you. But I mean, in my early years, I probably would have done the main branch first. When we are with our experience, we feel confident that we can do the side branch first. The advantage of doing main branch first and then going to the side branch is you will not miss the ostium. You will always have metal coverage of the ostium because you can make the stent project back into the main branch as much as you want.
And it is a left dominant system, you know.
So we are now dilated with 1.5
negative,
and now we are taking a 2.5 NC. We are ready for a kiss.
Negative.
So the way we did it, the way we approached, there was a small possibility that we may not be able to do a final kiss. But apart from that, I think the technique was pretty safe when we think of this complex scene. Okay, get me a 3.0 for...
Subroto, get ready.
3.0 for LAD. Oh.
Where? I think it's...
Many would ask whether this is an O balloon, but this is an N balloon, only opened up to pre-dilate the lesion. But expectedly it's not going. So let's take a 2.5 NC. I was really impressed by the alpine trackability. There are many times it has happened when you're taking stent through stent, the stent keeps hitting the previously deployed stent. And Come to Arya Cornell. Get a 2.5, please. Okay, go 11 quarter. Yes. So I think in this case we'll do a final case. Anybody would worry about, show the last image in 11 quarter here. About the LED, what is your thoughts on LED? Show contrast in LED. And previous view.
Go the spider also.
I think LED mouth looks pretty good to me. Yeah. So I think we could sort of accept.
It's a guide wire bias.
So again, the balloon is unable to go. The first 1.5 balloon went very easily. This is a 2.5 NC and it crosses.
It was guide wire bias.
Get me a 3.0. 3.0 on the LED.
Negative. Negative. 3 on the circumflex.
3 on circumflex, sorry. So I think we used hydrophilic wires pretty much in this case. We use run through hypercoat. One minute, we'll come. And then we also use cross 100. Okay, let's go. Let's go together. Go to 8, 10, 12. Okay, deflate. Okay, we are going again. Go to 8. Okay, on Sir Remus. Remus goes to 15. Come down on circumflex. 5. Okay, Remus come down to 5. Circumflex go to 15. Okay, both to 12. Both to 14. Okay, coming down 4 to negative. Blood pressure is coming down. And blood pressure is back to normal. So we could take a stent boost at this stage, but we are not in a position to show you the stent boost. So we take one picture and we come out.
The pot has been done already with a 4 milliliter balloon in the past. I think there are
two balloons, so
it's physical
the image is not the best, but good enough to tell you that you can withdraw the balloons. So we are actually pulling out the balloons. We'll show you one last picture, and then I think we'll have to say bye to you.
Wire is coming out. Okay. The other balloon. We can do with this balloon also. Okay, this should be okay.
So we take a picture for you all. Okay, ready? 1 minute. Huh? Okay, take one more picture, please. Ready?
Yeah.
Come to Arya Caudal. So I think the LED mouth looks quite good to me. So we can stop. What does everybody think there?
Okay, I think so. This is excellent result, and thank you for nice demonstration. One point is that which kind of the antiplatelet you recommended for this case, and how long?
Actually, in both the cases, this is a very interesting point, because both the patients earlier have been on clopidogrel, and they have been pretty good. So they are clearly responders to clopidogrel. So I had no hesitation in continuing with clopidogrel. But as is the style, any complex seen these days, my fellows like to give either Tricaglor or Prasugrel. So this patient is on Prasugrel. I'm really worried about the previous girl because she's only 38 kilos. And there was a discussion, and then there we did not give the Tricaglor or Prasugrel. We continued her on Clopidogrel. So Clopidogrel responders, like previous stent, functioning well, and you're very confident that they have had no stent thrombosis. I'm quite happy continuing them on Clopidogrel. Though the younger ones, they keep thinking that we should be giving the newer antiplatelets.
Yeah.
Thank you, Dr. Hiremath. That was one demonstration of skill and technology. Thank you.
Okay, this is the gift which has come from Dr. Fazila Malik from the National Heart Foundation, and all of us at the department, including Dr. Hiremath, we acknowledge it and we are thankful to you.
Fazila, this is going to be in our cath lab. Thank you indeed.
Thank you.
Thank you very much.